Hello there. Good evening, everyone. Welcome to our 2021 Adult Epilepsy Conference. My name is Missy Dalloway. I am the president and CEO for the Epilepsy Foundation, Eastern Pennsylvania. We are so happy to have you join us this evening so that we can learn together and continue our epilepsy education. Just a few housekeeping notes before we get started on our program. So your audio and video will be off for the entirety of the program this evening, so you can sit back and relax and not have to worry about anything except tuning into our presentations. This webinar is being recorded, so we will be sharing it with you after the fact, as well as posting it to our YouTube channel if you'd like to go back and watch any of the presentations again or share it with a friend who might be interested. If you'll notice at the bottom of your screen, there's a chat box. Please feel free to put any questions that pop up in the chat box whenever they come to you. You won't be interrupting any presentations. We'll be holding all questions until the end of the presentation. So please feel free to put your questions in there or just pop in to say hello. We love to see who's joining us this evening. I wanted to share a few epilepsy stats and facts with you before we get started. So epilepsy is often thought of as a rare disorder, but I'm sure many of you have heard that 1 in 26 people will be diagnosed with epilepsy at some point in their lifetime. There's an estimated 3.4 million people in the US living with epilepsy, and that's estimated to be about 3 million adults and 470,000 children. And I think what's interesting about that 3 million adults is that so many people assume that if you have epilepsy, that you were born with it or were diagnosed as a child and have had epilepsy your entire life. But I'm sure many of you joining this conference this evening, maybe you were diagnosed as a child. Maybe epilepsy hit you out of nowhere as an adult. There's a lot of contributing factors that can lead to epilepsy, such as a traumatic brain injury or stroke. So, it's something that we try to educate the general public on, that epilepsy can really affect anyone at any time in their life. And in fact, there is an estimated 110,000 people in Eastern Pennsylvania alone living with epilepsy. So a little bit about us at the EFEPA. We serve the 18 counties of Eastern Pennsylvania. Our office is located in Philadelphia, but we have dedicated resource coordinators living and working directly in their communities. So we go all the way up to the Wilkes-Barre-Scranton area, out to Lancaster, the Lehigh Valley, and everywhere in between. So we are here as a patient advocacy group. So essentially where the doctor's appointment ends, that's where we step in to help you navigate your diagnosis. So we provide a wide range of support services, educational programming, information and referrals, resources, whatever we can do to help you in your fight against epilepsy. We're here as that partner and friend. On the screen, we have some of our programs and services highlighted. I'd love to just run through them quickly with you. So seizure recognition and first aid training, that's one of the best things that we do at the foundation. We go into the schools, businesses, companies. We work with first responders and law enforcement to lead seizure recognition and first aid training. If you'd like us to come into your company to have employees and colleagues trained in how to recognize the signs and symptoms of a seizure, how they can respond and help, we would absolutely love to set that up. So many of our programs and services right now, we're still offering virtually. We're really excited that soon we'll be able to do those in person again. But it's really easy for us to set up. And again, we think it's education and teaching the public how they can recognize a seizure and how they can help if they should see someone having a seizure. We think that that's one of the best things that we can do, is spread that education. We offer monthly support group meetings all throughout our region. Again, those are held virtually right now, so that you're able to tune into any of them as they fit into your schedule. We offer a lot of great community building and awareness events. such as our 4 Walk 10 epilepsy events that I'll tell you a bit more about in a little bit, as well as educational conferences and webinars all throughout the year, such as the Adult Epilepsy Conference that you are tuning into this evening. We offer information and referrals, medical referrals, mental health referrals, legal referrals, you name it. We have information and resources that we can share with you to help you in any way that we can. We offer a wide range of youth and young adult services. We have our monthly Youth Achieve meetings, our Young Friends of the Foundation group. This past weekend, we just hosted a really wonderful young adult retreat. And then next up, we have our Camp Achieve in August. That's for young kids ages 8 to 17 living with epilepsy. And in September, we have our Adult Wellness Weekend. So that is for the 30 and over crowd. And it's not only open to individuals living with epilepsy, but also parents, spouses, and caretakers of someone with epilepsy. So definitely something to keep an eye out for as we make announcements about that for this September. I wanted to take a quick moment to really spotlight and thank our generous sponsors. Our corporate partners really make our work possible. They help us financially to put on our events and programs. So many of them are involved in boards and committees and volunteerism. Our corporate sponsors are so dedicated to the cause, to helping the epilepsy community, and they really help advance our mission and our work and really make our work possible. So first and foremost, I wanted to give a huge thank you to Greenwich Biosciences. They are our presenting sponsor across all of our conferences and webinars this year. They've sponsored all of our educational programming. So we're so grateful to Greenwich Biosciences for all of their generosity. And with that, I wanted to introduce Jennifer Cesaretti, our friend from Greenwich Biosciences, to say a few words. Jen, are you with us? Okay, I'm not sure if Jen is having some technical difficulties. Oh, we have Mike from Greenwich Biosciences who can pop in and say a few words for Jen. So Mike, take it away.
Hello. Thanks, Missy. Can everybody hear me?
Yes, we can.
Okay. Thanks again, Missy. Hi, everyone. My name is Mike Pifer. I am honored to be speaking to you virtually today on behalf of Greenwich Biosciences, which is now a part of Jazz Pharmaceuticals, and our entire team. As a sponsor for today's Adult Epilepsy Conference, Greenwich is proud to partner with the Epilepsy Foundation of Eastern PA for events like this to help people stay connected in this virtual environment. We're united in what we're trying to accomplish here today, to raise epilepsy awareness and to have a positive effect on care, on research, and on the lives of those who are impacted by seizures. There are so many families who wake up every day to the reality of epilepsy. There are people listening to this right now who have been fighting against it their entire lives. And there are others who are not able to join us today. But as a community, we never give up the hope that one day we will overcome the challenges of living with this disease. This is what drives us. You may know us best as a company researching and delivering FDA-approved cannabinoid medicines to help address serious conditions, but also know that our focus is on you. Patients and families are the center of everything we do, and we strive to make a positive and meaningful difference in their lives and in your lives. Today and every day, we are proud to be here with you, virtually and in real life, to raise awareness, take action, and continue the fight to end epilepsy. So with that, have a great event, and thank you for allowing us to be part of it all.
Thanks so much, Mike.
You bet.
So next, I wanted to recognize and thank our conference series sponsors, ASI and UCB. Our partners at ASI and UCB have sponsored our entire conference series our entire conference series this year. So a huge thank you to ASI and UCB for their generosity. With that, I wanted to introduce our friends at ASI to say a few words.
Hi, can you hear me?
Yes, we can. Michelle, now we can't hear you.
It's okay. Can you hear me now?
Yes, yes.
Okay, great. Hi, everyone. My name is Michelle Ziobro, and I'm with ASI. At ASI, human healthcare is our goal. We give our first thought to patients and their families and helping increase the benefits of healthcare provides. As the United States subsidiary to the Tokyo-based ASI Corporation Ltd, we have a passionate commitment to patient care that is the driving force behind our efforts to discover and develop innovative therapies to help address unmet medical needs. To learn more about ASI, please visit us at asi.com or follow us on Twitter and LinkedIn. Thanks so much for having us sponsor you tonight.
Thank you, Michelle. Thanks for joining us.
Thank you.
Next, I wanted to invite our friends from UCB to say a few words.
Hi, Missy. Thank you. Hi, everyone. My name is Nicole Betty, and I work for UCB, where we are inspired by patients and driven by science. Every day, one of our priorities is to improve the lives of people living with epilepsy, and we're committed to advancing research and finding solutions. We are so thrilled to be here and be one of your sponsors tonight, and we're happy to work side by side with the Epilepsy Foundation of Eastern PA and all of you so that together we can overcome epilepsy.
Thank you so much, Nicole. We're so happy to have you join us this evening. So last but not least, I wanted to give a huge thank you to our vendor sponsors. I'm sorry, that's actually not our vendor sponsors up there on the slide.
Hey, Missy,
yes.
let me share the updated version, okay?
Okay, thank you.
So just give me 1 second as it loads.
Bear with us, guys. We have been doing the virtual learning for, I think we're in like 15 months now, but we're still working out some kinks. So we appreciate your patience. Here's our wonderful vendor sponsors. So our vendor sponsors have sponsored our adult epilepsy conference this evening. We are incredibly grateful to them for all of their generosity. Biocodex, SK Life Science, Supernus Pharmaceuticals, and VNS Therapy by LivaNova. I would like to introduce our friends from SK Life Science to say a few words. Is Deborah with us?
Missy, can you hear me? It's
Yes.
Stephanie.
Hi, Stephanie.
Hi. Yeah, I don't know what's going on. I know Debbie's on, but I'm not sure what's going on. It sounds like there are some technical glitches
On
tonight, maybe.
now. She is a panelist right now. She should be able to speak.
Hello, can you hear me?
Hi, Debbie. We can hear you.
Oh, I'm so glad. So I'm Debbie Patterson, and I just want to first thank the foundation and the community and everyone to having us today. We're so excited to be here. As we all know, epilepsy is more than just seizures, and it takes more than one person to fight it. Here at SK Life Science, everything we do is with the purpose of supporting patients, caregivers, and the entire CNS community. We are a global pharmaceutical company focused on research, development, and the treatment of the central nervous system disorders. And we're also the US subsidiary of SK Biopharmaceuticals based in Korea. In addition to having a treatment approved in the US for partial onset seizures in adults, the companies have a pipeline of 8 compounds in the development for CNS disorders, including epilepsy. Our mission remains the same. As long as there are unmet needs in the epilepsy and CNS community, we will keep working. We will continue to explore the complex mysteries of the brain to find answers for patients, caregivers, and healthcare professionals because you're worth it. For more than 50 years, the Epilepsy Foundation has been fighting on the front lines to advocate and support the 3.4 million people with epilepsy here in the US. We share the foundation's sense of urgency and its deep commitment to addressing the needs of people with epilepsy by increasing awareness, innovation, and opportunities for community connection. We are thrilled to be partnering with the Epilepsy Foundation in the fight against epilepsy, and we look forward to helping advance the mission to end epilepsy. Together, we can make a positive impact, and it's time to take action. Again, thank you so much for inviting us this evening. We're thrilled to be here and support the epilepsy community.
Thank you so much, Debbie. And thank you for volunteering at the Young Adult Retreat this past weekend. I heard that you were a huge help. So we're always grateful for that.
Oh, you're so welcome. Anytime.
So moving right along, I wanted to quickly spotlight 2 of our upcoming events. So we have 2 of our Walk 10 Epilepsy events in June, and we have 2 of our Walk 10 Epilepsy events in October. So the ones coming up in June, we have our Walk 10 Epilepsy Lehigh Valley on Sunday, June 13th, and our Walk 10 Epilepsy Philadelphia on Saturday, June 19th. So we're really excited for these 2 walks because we are going to be doing them as a hybrid event model. Now, what that means is that we're going to be live streaming our opening welcome programs, our opening ceremonies over Zoom and Facebook Live. So you're able to tune in from home. And then if you'd like to walk your neighborhood or your communities, you're more than welcome to do that. But if you're ready and feel comfortable to come out in person, we have staggered arrival times for teams to come out and walk in person this year, which we are so excited about. And so for the Walk 10 Epilepsy Lehigh Valley, that will take place at the Upper Saucon Township Community Park. And for the Walk 10 Epilepsy Philadelphia, that will take place at Citizens Bank Park. So we're really excited to be safely getting back to in-person events, but also being inclusive of those choosing to join us from home. So if you're ready to register and get signed up, you can go to epilepsywalklv.org or epilepsywalkphl.org. I also wanted to quickly spotlight Camp Achieve coming up this August 16th to August 20th. Again, we're going to be doing a bit of a hybrid model for this for Camp Achieve as well. Camp Achieve is for children 8 to 17 living with epilepsy. So we are going to be doing essentially one day at camp for each age group, Monday to Wednesday, and then virtual programming elements as well for Thursday and Friday, and also for the kids that aren't able to join us in person this year. We are continuing to monitor our current guidelines and restrictions to see if we are able to change the format for camp this summer. It's a constantly changing game that we're just trying to make sure that we're doing everything right and safely. But we definitely encourage, if you have a child at home living with epilepsy, it is just the most magical place on earth. And it's one of our very favorite programs, and it means so much to our kids. So definitely get them registered by visiting efepa.org/camp-achieve. So that's it for me. At this point, I would like to turn it over to my friend, Carrie Miknia. She is our Lancaster and Berks County Resource Coordinator and the host of our Adult Epilepsy Conference this evening. So I will turn it over to her to take it away.
Hello, everyone. Thank you for joining tonight. Rena, I'm not sure if you can give me, there we go. Thank you for joining tonight. We are going to get started right away. Here's just a very tentative schedule, I guess. I would like to get started so that we can honor the time of everyone joining and all of our speakers. As Missy said, my name is Carrie Miknia. I serve as the Lancaster Resource Coordinator, and I service Lancaster and Berks counties. So without further ado, let's go to our first speaker that we have with us. Tonight we have Dr. Acharya. He is a neurologist at Penn State Health in Hershey. So Dr. Acharya completed his medical school training and residencies in internal medicine and neurology in India before moving to the US. He completed a fellowship in epilepsy and clinical neurophysiology at the Cleveland Clinic Foundation. Subsequently, he worked as an assistant professor of neurology at the University of Pittsburgh and as an associate professor of neurology at St. Louis University before joining Penn State Health in 2009. He's a tenured professor of neurology and chief of the Division of Epilepsy at Penn State Health. He is also the director of the Level 4 Comprehensive Epilepsy Center, director of the Epilepsy Monitoring Unit, and co-director of the Clinical Neuropsychology Physiology Lab, and maintains a busy clinical practice at Penn State Health. Dr. Acharya is board certified in neurology, clinical neurophysiology, epilepsy, and sleep medicine. He's the recipient of numerous honors and academic research and teaching awards. He is listed in Best Doctors in America and has been awarded the title of Distinguished Educator at Penn State. So we have Dr. Acharya with us, and he's going to be speaking tonight about epilepsy and wellness. We're so happy to have him.
Thank you, Carrie, for that wonderful introduction and for inviting me to speak at this conference. And good evening, everyone. It's a real pleasure to be here with all of you today. And I want to thank you as well for taking the time out of your Tuesday evening to be here with us. Special thanks to Missy as well for inviting me to be part of the professional advisory board for the Epilepsy Foundation. So I'm going to start sharing my slides. So I hope everyone can see my slide. If you cannot, let me know.
We can see it.
Okay,
we can see
great.
it, Dr. Acharya.
Thanks. Yeah, given all the technical glitches we've been having today, I just wanted to make sure. So good evening again, everyone. And what I'm going to do today is to talk about something that is not discussed often or in as much detail during your regular visits with neurologists or epilepsy specialists, where the emphasis is mainly on seizure control, treatments, tests, so on and so forth. But patients with epilepsy are more than just seizures. And you want to have a sense of well-being as well. Now, in order to achieve that sense of well-being, you not only need adequate seizure control, but you also need to adopt appropriate and healthy lifestyle. And this is what I'll be focusing on today. So I have no financial disclosures that are relevant to this presentation. And here's a quick outline of my presentation. So I'll start with a brief discussion about the concept of wellness in relation to epilepsy, and then provide a very quick overview of the management strategies used for epilepsy, and then spend essentially all of my time talking about special aspects of lifestyle that are helpful not only for seizure control, but also for the sense of well-being that I mentioned. So when you think about wellness, it is not just the absence of disease, which in this case would be seizures, but a positive state of complete physical, mental, and social well-being. So the attempts to achieve wellness ideally should be self-directed and community supported. For instance, through places or organizations such as the Epilepsy Foundation. And self-management, which comes from you as a patient, involves two main aspects. One is the epilepsy-specific management, which involves things like seizure tracking, writing down when you have your seizures, the severity, duration, keeping track of your medications, the timing, the dosage, so on and so forth. The other aspect of self-management is managing life with epilepsy, where we look at a variety of other dimensions as well. And so this is the so-called wellness wheel that appears on the Epilepsy Foundation website, which lists various dimensions of wellness. And I'm going to talk about some of these, and the other speakers will probably cover a couple of additional ones as well. And so when we broadly look at the management of epilepsy, there are four main types of treatments available, with the core treatment being anti-seizure medicines or drugs. Now, in some patients, that is enough to lead to seizure freedom, but in some patients with what's called drug-resistant or pharmacoresistant epilepsy, you may need additional forms of treatment, such as surgery, neurostimulation, or the ketogenic diet. But there's also a fifth component to treatment, which is often not given as much importance as the other four, but which in fact is essential, not only for seizure control, but also to provide that sense of wellness, which is looking at lifestyle factors. And so to paraphrase the famous British author Somerset Maugham, who said, "Money is the sixth sense without which you cannot make full use of the other five. Lifestyle is the fifth form of treatment without which you cannot make full use of the other four forms of treatment." So why is lifestyle so important? Well, changes in lifestyle can result in breakthrough or provoke seizures in patients who otherwise have well-controlled epilepsy. Modification of lifestyle can also either improve or worsen seizure control in patients who have uncontrolled epilepsy. And as I mentioned earlier, lifestyle choices can also improve your overall health and well-being. So the factors that I will discuss in my presentation today are sleep, nutrition and alcohol, stress reduction, medication adherence, and various triggers that are known to precipitate seizures, such as fever, trauma, drugs, and flashing lights. Epilepsy and sleep have a sort of a complicated relationship with each other. It is also bidirectional, which means that epilepsy influences sleep, and so does sleep influence epilepsy. So starting with the effects of sleep on epilepsy, in terms of timing, approximately 20% of patients have seizures that occur predominantly at night. And it has been found that the peak occurrence is either within 2 hours of sleep, an hour before waking up in the morning, or shortly after you wake up. It tends to be more common during non-REM sleep than REM sleep. And most of you are probably aware that there are 2 types of sleep that we go through every night. The non-REM or the non-rapid eye movement sleep, which is in turn divided into 3 stages, N1, N2, and N3, with N1 and N2 constituting light sleep and N3 being deep sleep. And then the other type, which occupies about 20 to 25% of our sleep, the REM or the rapid eye movement sleep. We tend to dream and also have nightmares, most often during REM sleep. So if you look at this diagram, non-REM sleep tends to be the most epileptogenic. In fact, you're more likely to have seizures during non-REM sleep than when you're awake. On the other hand, REM sleep seems to be somewhat protected in that it's unusual for patients to actually have seizures arising out of REM sleep. Both focal and generalized seizures can occur during sleep. In terms of focal seizures, we most often see what are called complex partial, or to use the new term, focal impaired awareness seizures. The classic nocturnal seizures are the ones that arise from the frontal lobe, where you can have either hypermotor seizures, where patients abruptly wake up and have wild movements of the body and may sometimes even shout out or have other forms of vocalization. And the other type is what's called bilateral asymmetric tonic seizure, where they may flex one arm while extending the other. Temporal lobe seizures, although they may not necessarily occur more frequently during sleep, are more likely to evolve further into generalized tonic-clonic seizures during sleep as compared to wakefulness. Non-REM sleep tends to activate frontal lobe seizures more than temporal lobe seizures. With regard to generalized tonic-clonic seizures, about 44% of patients report seizures occurring exclusively during sleep. About a third of patients have them when they are awake, and about 23% have them at any time, randomly. Myoclonic seizures tend to occur most often shortly after you wake up. There are also a number of epilepsy syndromes that have been specifically linked to sleep or awakening. And I've just listed some of them here. I'm not going to go into the details of these. One of them is Artisanal dominant nocturnal frontal lobe epilepsy. Another one is benign childhood epilepsy with centrotemporal spikes, also known as benign Rolandic epilepsy. Then there's a rare condition called epilepsy with continuous spike waves during slow wave sleep. And lastly, juvenile myoclonic epilepsy, where patients typically have seizures not during sleep itself, but shortly after awakening or in relation to sleep deprivation. So sleep deprivation can cause clinical seizures, both when you have total or partial sleep deprivation. And this tends to be most common in patients with awakening epilepsy, such as patients with juvenile myoclonic epilepsy. Sleep deprivation can also change your EEG findings. It has been found that total deprivation can activate epileptic discharges in 23 to 93% of patients. Partial sleep deprivation can also activate discharges. And many of you may have undergone either EEGs in the lab after sleep deprivation or have undergone sleep deprivation during your stay in the epilepsy monitoring unit. And so this is the reason we do it. Although sleep itself, especially non-REM sleep, tends to increase your chances of having both discharges and seizures, sleep deprivation has an additional effect. So there is an apparent genuine activating influence on the EEG beyond sleep induction with sleep deprivation. Now, looking at this from the other point of view, what does epilepsy do to your sleep? So patients with epilepsy tend to have disruption and lability of REM sleep and tend to spend less time in REM, which is unfortunate because REM is the protective part of sleep, as I mentioned earlier. Patients also have reduced total sleep time and efficiency. There is prolonged onset of sleep or REM sleep, increased number of arousals, awakenings, and stage shifts. And unfortunately, although seizures themselves can understandably disturb sleep architecture, this type of disturbance can occur even in the absence of seizure. And it occurs in patients with both generalized and focal epilepsies, most commonly in those with temporal lobe epilepsy, and less commonly in those with frontal and generalized epilepsy. There's also an interaction between sleep, epilepsy, and your anti-seizure medications, which often ends up creating a vicious cycle like this. So if you have a sleep disorder or some of the anti-seizure medication that you take can result in sleep fragmentation, which in turn results in seizures, further reduces your seizure threshold, and so on and so forth. The disruption in sleep as well as the seizures also result in excessive daytime sleepiness, can cause adverse effects on learning and behavior, and reduces the quality of life overall. Treatments such as VNS can also have effects on sleep, and they can be both negative and positive. So the negative effects are decreased REM sleep and increased awakenings and stage non-REM 1 when the current strength is above 1.5 milliamps. More significantly, VNS can also predispose patients to obstructive sleep apnea by altering the upper airway muscle tone or by affecting central mechanisms. And one way to reduce this is by reducing the stimulus frequency from 30 to 20 hertz, which is something I routinely do for my patients. On the other hand, VNS can also have some positive effects. It can improve daytime alertness. It can improve the quality of sleep and macro architecture, increase delta power, so on and so forth. Now, lastly, patients with epilepsy are not immune from having primary sleep disorders as well. But they also have very prominent sleep-related symptoms. The most common one being excessive daytime sleepiness, which can result, as I showed you earlier, not only from seizures, but also from anti-seizure medicines. Patients also often report sleep maintenance insomnia, which means you fall asleep and then you wake up afterwards. This tends to be more common with temporal lobe seizures and in general with poor seizure control. Among primary sleep disorders, obstructive sleep apnea, whether or not you have a VNS in place, it appears to be more common in patients with epilepsy. Epilepsy can worsen obstructive sleep apnea. And on the other hand, treatment of obstructive sleep apnea with CPAP can improve seizure control. So after having given you all this information, here are some practical management tips for you. So in general, it is very important to get adequate sleep and to avoid sleep deprivation. If you have either sedation or insomnia, please discuss this with your physician, especially if you think that it may be related to your medications so that we can adjust them. If you have a sleep disorder such as obstructive sleep apnea, make sure you get investigated and treated for this. And then lastly, there is increasing interest in what's called chronotherapy. So if someone has seizures at a certain time of the day or night, so for instance, if someone has seizures most often at night, we can adjust your dosing in such a way that you get most of your medicine dose at that time. So if you have nocturnal seizures, your night dose can be higher than your morning dose. And in this way, we can provide better seizure control without increasing your total daily dose, which could cause side effects. This can also be done with certain devices, especially the VNS system, where you can have differential levels of stimulation for day and night with the latest model. Also observe basic principles of sleep hygiene, which are important whether or not you have epilepsy. And I'm not really going to read out each one of these things to you. So you can take a look at this. In general, limit caffeine, avoid alcohol and nicotine prior to sleep, limit working starting late at night, exercise early in the evening, take warm showers, back rubs, relaxation exercises, limit naps, try to limit your anxiety and worry or write it down, think about it during the daytime. And I guess this last part is important. If you can't fall asleep within 15 minutes, don't keep tossing and turning in bed. Get up and do something else for about 15 minutes and then try to sleep again. Moving on to nutrition and diet, here are some general recommendations. Have a well-balanced diet, eat at consistent times, and avoid long periods without food. Low blood sugar or hypoglycemia can cause seizures, although it's unlikely to happen if you miss one meal, unless you are diabetic. If you are sensitive to certain food types, avoid these foods, but be careful about fad diets or about things you just read on the internet. So if you have any doubts, talk to your physician. Also make sure there is no medical problem that's contributing to your food sensitivity and seizures. Regulate meal times and patterns around sleep, activity, and medication schedules. One way to remember taking your medicines is to time them around your meals. And this may also lessen the gastric distress that you can sometimes have with some of the medicines. But remember that there are some medicines that actually work better on an empty stomach. So again, talk to your doctor about this. If your appetite is poor, try small, frequent meals instead of skipping meals. Avoid any foods or drinks that may interact with your anti-seizure medicines. For instance, grapefruit juice is known to interact with one of the older drugs, carbamazepine. If you are following a diet specifically for your epilepsy, such as the ketogenic diet, be sure to follow the advice of your doctor and nutritionist about specific foods and amounts. I also get a lot of questions about caffeine use from my patients. And unfortunately, the recommendations are not clear because there are conflicting reports. There are some studies that suggest that since caffeine is a stimulant, it could potentially increase your seizure susceptibility. But there are other studies that suggest that if you take caffeine on a regular basis, it may actually protect you against seizures. So the jury is still out on what you should do with regard to caffeine. There's also some evidence that caffeine can lower the efficacy of certain drugs, such as topiramate. Since I did bring up the issue of dietary treatments, I thought I would quickly share this slide with you. Many of you are aware that the keto diet is very popular now for losing weight. And perhaps many of you also know that the ketogenic diet has been around for several decades as a treatment for epilepsy, particularly drug-resistant epilepsy. So there are many different types of diets that are available, and they all have varying proportions of fat, carbohydrate, and protein. But the general principle is that for seizure control, you need a diet that is high in fat and low in carbohydrates with variable proteins, often with vitamin and mineral supplementation. We don't know exactly how this works, and there are a number of different theories that I'm not going to get into. Over the last few years, we've been focusing more on the modified Atkins and some of the other diets that are more palatable for patients and do not require inpatient stay in the beginning or fasting. It is important to realize that these diets don't work instantly, and you have to stay on them for at least 3 months for you to see significant benefit. And as you can imagine, that can sometimes be difficult in terms of staying on a diet for that long. What about alcohol? Well, I have some good news and some reassurance for you. In the past, we often told patients not to drink at all, but there is increasing evidence that suggests that in small amounts, alcohol does not cause seizures. So that a drink or two now and then does not increase seizure activity. Small amounts of alcohol also do not change the amount of seizure medicines in your blood or findings on your EEG studies. When alcohol is actually related to seizures, it's not the alcohol drinking itself. It's more often the state of alcohol withdrawal that causes seizures. And it has been found that if you have more than 3 or 4 alcoholic beverages, you're more likely to have seizures. Binge drinking and alcohol withdrawal can be quite dangerous because it can even lead to status epilepticus, which, as you know, is a life-threatening and potentially fatal issue. And so again, in terms of practical tips, what should a person with epilepsy do? Avoid binge drinking. And what that means is that for males, you should not have 5 or more drinks in 2 hours. And for females, no more than 4 drinks in 2 hours. Don't abuse alcohol. So, because this can increase not only the risk of seizures and withdrawal seizures, but also the risk of you developing epilepsy over time. Avoid stopping alcohol suddenly or reducing by large amounts over a short period of time, because seizures may occur even in patients without epilepsy. So the bottom line is that if your provider okays alcohol, use moderation, which is true of almost anything in life. What that means is only a few drinks, less than 3, and drink slowly, avoid binge drinking. Moderate to heavy alcohol use is never recommended. Remember that alcohol and some of the anti-seizure drugs have similar side effects. So when you use both at the same time, you can have significant problems. Be especially careful about drinking and driving when you also take anti-seizure medications, because both of them can affect your awareness, reflexes, coordination, and ability to drive safely. What about stress and epilepsy? Now, emotional stress can be a seizure trigger for some people, and it's also both the cause and symptom of a variety of mood problems, such as anxiety and depression. So do track your stress level and mood in relation to your seizures. Write it down in your diary. When you are undergoing stressful times, look at ways to modify your lifestyle and manage your stress better. If necessary, consider counseling to help cope. Consider support groups. And so the Epilepsy Foundation is a great place to share and discuss your situation. Write down your feelings in a diary on a regular basis. This sometimes helps to get them out so that you don't keep them inside and keep brooding about them. Use timeout periods. This also allows you to take a step back from the stressor and sort of think about how you want to deal with it. Both exercise, including relaxation exercise, deep breathing, yoga, and other strategies can be helpful. Make sure you get enough sleep. Set priorities for what's important in your life. And ultimately, be sure to discuss this with your doctor and nurse, particularly if you feel that you are in a state where you are emotionally unsafe. You may even consider going to an emergency room to be evaluated. There is increasing evidence that behavioral interventions, which is a broad term that includes not only the formal psychobehavioral modalities like cognitive behavioral therapy, but also other forms of mind-body treatment, such as mindfulness or progressive relaxation, yoga, and meditation, along with other forms of therapy, such as art and music therapies, can help patients with epilepsy, not only in terms of reducing seizures and epileptiform activity on EEG, but in terms of improving the quality of life and comorbid mood disorders. Physical exercise is also good for you. And again, the good news is that most individuals with epilepsy can safely exercise in a gym, use exercise equipment, and do other types of exercise. But be careful to pace your exercise, avoid hyperventilation or getting too tired. Avoid exercising in the middle of the day during hot weather. Make sure you're well hydrated. Carry rescue medicines and identification information if your seizures are not controlled. Exercise in a safe place, such as riding a bike on bike paths, playing ball on grass rather than hard surfaces. A couple of things that I often tell my patients is to be careful with free weights such as dumbbells. You're probably better off with weights that are attached to machines in case you end up dropping it from having a seizure. Similarly, treadmills also require some caution. What about sports? Contact sports such as football, rugby, basketball, etc., are generally safe for people with seizures. You can also indulge in some forms of water sports, but be careful. Try to have a buddy with you, use a life vest, have a medical alert bracelet. There should probably be someone in your group who knows about seizures and the fact that you have them, and also knows how to provide basic life support. If you have uncontrolled seizures, there are certain activities that you should probably avoid, such as scuba diving, rock climbing, skydiving, and the others listed here. Another thing that is very important to keep in mind is to take your medications regularly. Because when you miss a dose, or if you take your medicine irregularly, you are at greater risk of having seizures. And you're also more likely to have side effects. Now, I realize that epilepsy is a chronic condition, and many of you take multiple medicines, sometimes more than once a day, and that you take this over several years. So it is human to occasionally miss a dose or two. But there could also be other reasons for adherence problems, such as memory problems, side effects, or sometimes the instructions that we as physicians give you may just be too complicated. If something like this occurs, try to sort out the reason and try to find an easier way of taking your medicine. And you can reach out to us and we can work with you. You can also try and maintain a diary where you can compare what happens when adherence is a problem versus when you're taking your medicines regularly, so that you can see for yourself. But again, I would not recommend experimentation by not taking your medication just to see what happens. Also, try to find out the reasons why you're having trouble with maintaining your schedule. That will make it easier to target the reason and to correct it. Use both a pill box and some form of an electronic reminder to help you both remember to take the medicine on time and then to confirm that you did actually take your medicine. Lastly, I'll talk about some seizure triggers. Now, if you have a fever, that can cause a seizure, and so can an injury, and sometimes other drugs, including over-the-counter medication. So whenever this happens, try to notify your doctor. And you may have noticed yourself that certain medicines can trigger seizures, or you may have been told that they can interfere with your seizure medicines. So try and avoid those. You also should monitor your seizures more carefully when you have one of these illnesses. Make sure that you stay well hydrated. If you are having trouble with throwing up, talk to your doctor to see if you can get something to help prevent that. If you're on a diet for epilepsy, learn how to manage your diet when you're sick, and try to limit your other triggers during these times as well. Lastly, I hear a lot of from my patients telling me that flashing lights or fluorescent lights bother them. And so I thought I would share some facts with you about photosensitivity and epilepsy. So photosensitivity is really an abnormal EEG response to light or pattern stimulation. And this is relatively common in that it occurs in roughly 0.3 to 3% of the population. But actual seizures from light are much less common, occurring in about 1 in 10,000 or 1 in 4,000 people between the ages of 5 and 24 years. Now, although photic or pattern stimulation can provoke seizures in people who are predisposed to it, possibly from a genetic basis, that by itself does not mean that these patients will go on to have epilepsy subsequently. Although there is a type of epilepsy known as reflex epilepsy, where patients can continue to have seizures only in the setting of photic or pattern stimulation. People who already have epilepsy have a 2 to 14% chance of having seizures with light or pattern, and this is more common in those with what we call idiopathic generalized epilepsy, such as juvenile myoclonic epilepsy. And that's one reason why we often use strobe lights when we do an EEG, or sometimes when you are in our epilepsy monitoring unit, in order to induce these discharges or seizures. Research studies have shown that intensities of 0.2 to 1.5 million candle power are in the range to trigger seizures, and that frequencies between 15 to 25 hertz are most provocative, although anywhere between 1 to 65 hertz can also trigger seizures. So again, when we use strobe light stimulation during the EEG, we typically use a range of at least 1 to 30 hertz to see if we can induce discharges. In terms of pattern-sensitive seizures, it's often light, dark borders that do this. And in terms of color, red color is more likely to induce seizures. And as many of you know, and some of you may have heard about what happened in response to a Pokemon game show many years ago in Japan, seizures can indeed be provoked by some TV shows, movie screen images, video games, and a variety of natural stimuli, such as sun on water or sunlight flashing through trees, a variety of public displays, etc. So the Epilepsy Foundation, the National Epilepsy Foundation, has actually established some guidelines to reduce the seizure risk with exposure to light. And again, I'm not going to read out all of these, but as you can see, there are guidelines about distance from a TV screen, video game screen. People with a family history should be careful, use good ambient lighting, avoid looking at rapid, flashing lights, alternating geometric patterns, don't play for more than 1 hour at a time, avoid sleep deprivation. If you feel you have some unusual visual symptoms, stop playing. And interestingly, it has been found that closing one eye or looking away from an image is of more benefit than is closing both eyes. So this whole idea of photosensitivity is of particular interest to me. And I'm currently on an international task force through the Epilepsy Foundation, actually, to establish updated guidelines to reduce seizure risk in response to light. And so this is likely to be published in a year or two, and then along with other members of the Epilepsy Foundation, we will share it with patients. Here also are some general guidelines to reduce the risk of photosensitivity as well. Use polarized or tinted glasses, natural lighting when you're indoors, focus on distant objects when riding in a car, avoid flickering lights or patterns, avoid discos, strobe lights, or flashing bulbs on holiday decorations, and use a computer monitor with minimal contrast glare or use a screen filter. So this is all I have, and I hope that not all of you are in one of these two situations. And despite what my cartoon says, I'm certainly open to taking questions. Thank you.
Thank you, Dr. Acharya. That was great information. Let me see here. Okay, good. We are going to go ahead and move forward with the next. One moment. Does anybody have any questions for Dr. Acharya? Remember to put those in the chat box and we can get those. If not, we are going to move to the next presenter. Okay, so I'd like to go right ahead and introduce Dr. Vinita Acharya. She is an academic neurologist and epileptologist at Penn State Hershey Medical Center, again at Hershey. She's completed her residency training in India, University of Texas in San Antonio, and at the she completed her fellowship training in epilepsy and clinical neurophysiology at the Cleveland Clinic Foundation in Cleveland, Ohio. Her special interests include psychiatric issues in epilepsy, autism in epilepsy, women's issues in epilepsy, and pre-surgical evaluation of epilepsy. She is a well-respected member of the American Academy of Neurology, American Epilepsy Society, American Neurological Association, and plays an important role in these organizations and serves on many committees within those organizations. In addition to medicine, she teaches several courses in humanities, and this helps her in providing compassionate care to her patients and advocating for them in various situations. During the pandemic, she has developed expertise in optimizing telehealth visits for patients with epilepsy. She is board certified by the American Board of Neurology and Psychiatry in Neurology and Epilepsy. She has won several national and international awards. Without further ado, I would like to introduce Dr. Vinita Acharya. Thank you.
All right. Thank you, Carrie. Let me share my screen. Can everybody see my screen?
Yes, we can see your screen, Dr. Acharya.
All right. First of all, I would like to thank the organizers for inviting me for this conference. I'm so excited because what I'm talking today, while I was preparing this talk, I realized that this is not something we learn in books. And I have to thank all of you, all the patients and all the foundations, because this is something we kind of have captured from our experience, and the list goes on and on. So I'm going to talk about barriers to optimal epilepsy care. I do serve on advisory board for SK Life Science, but there are no disclosures that I have related to this talk. And what we will be discussing is kind of discover what are the locally offered epilepsy care services, learn more about advocacy, benefits of telemedicine, epilepsy surgery, some proper psychiatric and therapeutic care, and basically anything and everything that can help the patients with resources they need, work with the physicians as a team, and live the best possible life with epilepsy. And if you add anything to this list, I'll be very open. I want this to be interactive and kind of informal session. So once you're diagnosed with epilepsy, where do you go? So if it's complicated epilepsy, typically the best source to look for is the National Association of Epilepsy Center, NAEC. Now, they divide the centers into level 1, 2, 3, 4. 1 and 2 are kind of either emergency room, primary care physician, general neurologist, and 3 or 4 are more specialized. So the level 3 can perform some sort of surgeries. Level 4 is basically all kinds of complicated surgeries and including all the devices. And I'll be talking a little bit about that. So basically the accreditation is a long process that centers go through. And what we have here in Pennsylvania, this is a map of our NAEC accredited center, and it's there on most of the Epilepsy Foundation sites. But I've just summarized what centers we have. So there are 2 centers in our region, which are level 4, and both they see patients with both adult and pediatric epilepsies. That's Penn State Hershey and WellSpan. The advantage of being both centers being together are the transition of care becomes easy. So when children grow, they become 18, they can be easily transferred to the adult center. And then there are about 5 level 4 epilepsy centers we have. We have 2 pediatric epilepsy center. So what did I do? CHOP and University of Pennsylvania are kind of together, but still the transition sometimes can be difficult. And we have 3 level 3 centers in the area, St. Luke's, Temple University, and Lehigh Valley. So as you can see, Pennsylvania does have a lot of resources. And the most important resource important for patients is basically the Epilepsy Foundations. Epilepsy Foundation Eastern Pennsylvania, the group that has organized this meeting, as well as we have an Epilepsy Association of Western and Central Pennsylvania and epilepsy.com. So these foundations provide all kinds of support services and advocate for patients and community at various levels. So let's move on to advocacy. So what can we advocate for? So typically it's day-to-day life questions like school, work. So there is a concept called Seizure Smart Schools, and the advocacy is typically done by social media, by meeting with legislators, hosting a gathering, so on and so forth. So interestingly, I was just emailing this presentation so that we have a backup, and the email popped up from American Academy of Neurology, which said, speak to your legislation, email them. So what we are doing is that the organizations, the professional organizations are giving more and more access to physicians to contact the legislators. So some of the parts of these are rare disease access to care, and the newest one is Human Rights Act Amendment. This bill allows state agencies like Council on Disability and Council on Human Rights to be more responsive and support people with disabilities to get accommodations they need. Now, in terms of epilepsy, I can give you an example of this. About 3 years ago, I was contacted by one of the epilepsy foundations in the country, being a female epileptologist. And I don't know if anybody else has come across a situation like this. One of my patients, he had told me, oh, my wife is delivering a baby, and this was my hospital, Penn State Hershey. And it turned out that the wife also had epilepsy. And when they came for discharge planning and taking the baby home, there was a question whether 2 patients with epilepsy, 2 parents with epilepsy can take care of a baby or no. And that's a long story, but I can proudly say that when I was contacted, I really didn't know much about the issues. I did research and there wasn't much in the literature, but I was able to advocate for those people, the family, because both parents were well controlled. So every day we learn new and new issues to advocate, and we will continue to do that. So there was this group, Leadership in Epilepsy Advocacy and Development, and lead faculty. These are very prominent epileptologists in our field, Dr. Shankar and Tracy Glosser. And what they did in this study was they gave 26 epileptologists from different regions in the country a survey to see, if all patients with epilepsy receive adequate treatment. And apparently, what they found was not everybody does it. And that was the consensus. Apparently, they answered the survey independently and everybody felt the same. And they thought that if people cannot, sometimes the issues detected were mainly delayed recognition of seizures and inadequate treatment. And that could increase the risk of subsequent seizures, brain damage, disability, and even death from seizure-related injuries. So a consensus was reached that there has to be a minimum standard patient management. So everybody should get an access, if they have complicated epilepsy, to the highest possible care available in epilepsy. And we will talk about that. So in another example of, so to get that care, sometimes the complex centers, the comprehensive, the level 4 centers are far away for patients living in rural areas. Now, the telehealth kind of came into existence largely because of COVID pandemic. This was one of the positive kind of effect of COVID pandemic. But we realized, especially for our patients with epilepsy, this was very helpful. And as most of you may have realized, most patients with epilepsy do not have abnormalities on their neurological exam. They're otherwise very healthy, normal people, and it's just the management is about medications or do they need anything beyond medications. And the telehealth visits were not very different from in-person visits. And that saved them a lot of traveling, especially when people were not able to drive. So American Academy of Neurology actually has a conference now for 2 days just to advocate for telehealth. At our center, I actually involved a lot of medical students and medical residents and other physicians in telehealth. So those of you, many of you must have done telehealth visits. As a matter of fact, I have done telehealth visit on the other side too as a patient. And one of the advantages I felt was when you go for a doctor's visit, you keep waiting and you have no choice but to wait until the doctor shows up. Initially, the nurse will come, then part of time goes in triaging, then you wait for the doctor. On a telehealth visit, when you log in, you get a message that do you want to be contacted when your doctor is ready for you? And they just send you a text and you can go. But this is somewhat how the screen looks. Now, I don't know if you can recognize me. This is me here on the screen. This is my student. And there would be a patient on the other screen. And I'm not showing the patient for HIPAA reasons, but basically, it's somewhat like those who are familiar with the concept of Skype. It is two opposite screens and people are talking to each other. And one of the advantages I discovered was, just like I'm sharing my slides with you now, you can share your images, you can share pathology slides. And here it's me showing my MRI, and it does make a difference when you show the images and you have plenty of time, and just like you're teaching on a board, you show all the images, patients do get that better visual image. So what are the advantages we thought was, as I said, travel, and you can incorporate multidisciplinary conversations, radiology, pathology. One of the things I've found is family members can join. Oftentimes the family members of patients, they want to know who the doctor is and how they talk to their family member, and only one member can come for a visit. I have often had like 6 or 7 people joining on telehealth visit, and they all had different kind of questions. So you get an idea of the environment. And when you go for a real visit, you do spend a lot of time in getting roomed and appointment logistics, whereas here, most of the time is utilized for a visit. There are some disadvantages to it. There could be technical limitations, lack of interpersonal reaction, and sometimes when the physical exam is complicated, then you may not be able to do it as well as you do in-person visit. So in a visit, what happens? This is in-person or telehealth. I'm just saying in general, when a diagnosis of epilepsy is made, you do the initial evaluation. As most of us know, we start one medicine, we adjust the dose, assess the response, add the second medicine, and about 50% of people respond to the first medication. Additional 13% will respond to the second medicine. Sometimes we do add a third medication, and that adds another 4% response. There are about 33% people who are drug-resistant epilepsy. And no matter how many medicines you add, and even though they are potent, they don't respond to medications. In other words, their seizures continue. And in that case, we are exposing these people to seizure-related injury. Even concept of SUDEP has been rising, sudden unexpected death in epilepsy, increased hospital visits, ER visits, depression, anxiety, and developmental issues. So in general, I'm just going to briefly go over a map of what to do when we are diagnosed with epilepsy. So first of all, do the evaluation when the seizures are not controlled with 2 medications. And after the evaluation, if the surgery is appropriate, your doctor will tell you and you proceed with it. People, not necessarily everybody becomes seizure-free with surgery. So if the patient becomes seizure-free, that's fine. If they don't become seizure-free, even after surgery, there are 3 types of devices that we have. I'll talk about that in the next slide, but there is a vagus nerve stimulator, or VNS, and that goes in the chest. It sends an impulse across the vagus nerve and it goes to the brain and releases neurotransmitter. We have something called responsive neurostimulator, or NeuroPace. That's a device which is placed in brain. And recently, deep brain stimulation. That's the device most of you will be familiar, is used in Parkinson's. A very famous actor, Michael Fox, has that. And that's how my patients always tell me, oh, you're talking about that one. So there are 3 devices approved for epilepsy. And when surgery is not appropriate in the first place, we go for device, and there are these 3 devices that can be used. And that's when a specialized level 4 center comes in a picture. And what Dr. Shankar and Trossi Grosser's paper meant was, if needed, if a patient is so resistant to medication, every patient, no matter where they live, even in a rural area, they should have access to all of these measures. So again, when pharmacoresistant epilepsy, the evaluation is done at centers for medical therapy, epilepsy surgery, device therapy, and in addition for dietary therapy. And Dr. Jayant Acharya already discussed the diet, so I won't go into that. This is something, I guess it may look scary to some of them, but I just wanted to show the image of when people take surgical decision, why do patients need access to level 4 centers, is because we want to know where the epilepsy is coming from, what the origin, because in surgery, what is done is the part of the brain that produces surgery is literally either taken out, or even if a device is placed, it has to act on that region. So this is something called subdural grids, and these are called depth electrodes. So these electrodes are actually, many of you have had routine EEGs where we just place the stickers on the brain, as opposed to the surgeon literally, they do burr hole and they place this inside. And that is why when the epilepsy is so severe, we need access to these type of procedures. So there are several types of epilepsy surgeries. Typically for partial surgery, if it's coming from, most common procedure performed is temporal lobectomy. And if the focus of the seizure is somewhere else outside temporal lobe, then what we do is what is called extratemporal resection. I'm not going into the types of surgery, etc., in the details, but just kind of want to highlight that the surgery option is available for partial and generalized. We don't typically use it for generalized epilepsy. Mainly it's a palliative procedure, whereas in partial epilepsy, surgery can be really helpful. We do have a lot of patients who have become seizure-free. In fact, what I hear from patients is, there is a person from Lancaster actually who just stopped by a few days ago, and I was so worried. I thought, what happened? You were seizure-free for so many years. She said, I'm still seizure-free, but you never taught me how to live life without seizures. And that was her suggestion to me, because everywhere she would go for jobs, etc., people kind of thought that she had too many seizures and she had a problem adjusting to the new life. So moving on to other barriers, there are several educational barriers. About 1 in 2 students with epilepsy have some form of learning difficulty, and people can get help for learning problems which may be hard to detect. Also, we all know that students may have difficulty with language, memory, attention, and some medications can cause side effects and affect their learning and memories. And some type of epilepsy may have medical or neurological problems that can affect learning and school performance. So there are resources available. Many of you may be familiar with the IEP and 504 plans, and the schools can provide neuropsychological testing. I had one patient where I was so surprised to know it was a very rural area and the school did not have a school nurse. So I made a plan for the school. What happens if this child gets a seizure? And the school says, we don't have a school nurse. What I was able to advocate for was, because the school did not have a nurse, in view of safety, we were able to get a private school that had a nurse, which was nearby for this patient. Now, the school is children have a lot of resources. Now, patients with epilepsy, most of them are going to college. And I don't know if there are any college students here or parents of college students, but I deal with them a lot. And as a matter of fact, at some point, I tried to teach some of the college professors what to do in epilepsy. And I think they're more comfortable just calling 911. But I'm a faculty senator for our university, Penn State, and this is a major initiative that we have taken. We call it neurodiversity. Some of the things that we have been able to do, and I'm sure many other universities have, is something that was brought to me by my patients. For example, if there are any students, sometimes students have 3 final exams on the same day. So they take first exam 3 hours, then they have another 3 hours and another 3 hours. What happens to patients with epilepsy? Their effect of medication may wear off at that time, or they may just feel so tired and they are not able to do that. And I was able to kind of explain to the administrators that the final exam rule, what if other students, there is a limit on how many exams people can take. If it is 3 for rest of the people, for patients with epilepsy, it should be less. And we had a hard time putting a number, whether it should be 1 or 2. And in my opinion, every patient is different. So we need to assess that and we need to set it up. Now, what happens is the disability accommodations, as many of you may know, are done at the beginning of the semester. So the student does not know what they can take and what they cannot take, especially students in STEM field. Sometimes the labs can be difficult. They face several difficulties once the semester starts, and we have been able to make these adjustments. And this is a part of advocacy. And this is my request to you, that as you come across in any field, it doesn't need to be student or work. As I said about that, parents who were admitted to the hospital, please bring these issues to the attention of epilepsy foundations. Epilepsy foundations do a great job, and they will bring it to us as physicians, and we will kind of, there may not be any set rules for this, but this is a continuing work, and we need to go on and add things to this list. Again, employment barriers, many of you are aware of these, and specifically healthcare visitations or FMLA, many people do not declare their epilepsy. I think that sometimes ends up becoming a problem. I think people with epilepsy should do every work as, unless it's something dangerous to their seizures, most people are able to do all the, everything they can. What I have seen is some of the executives in the field sometimes are very scared to declare their epilepsy. I feel that no person with epilepsy should have that fear that what if I declare my seizures and my employer says you should not have this position. I think we should be able to work around that. And again, ability to drive, and that is not something we wish to do. As we all know, we get one seizure in Pennsylvania and patient is not able to drive for 6 months. And in that case, at times I have been able to work with my social worker, and we were able to find resources. For example, if somebody is working in a hospital, the hospitals have shuttles going in the area around. If the patient stays nearby, they could bring that person home. I did have this similar issue recently, And I also discovered that our state, there is, in this area, there is a bus ride called CAT ride. So patients don't want to wait for a regular bus, but if they have epilepsy and they need to go for their appointments, they have a concept of shared ride. That means at the time of their appointment, the bus organization will send a bus which is specifically for them. So we can compile the resources. I have done that for my area. So if a patient brings up an issue like that, we can see what are the transportations available. And typically these are given free of charge. So my patients who have it, they bring some kind of a slip given by that organization, and I sign the slip saying that yes, patient used it for a visit and they don't have to pay for these visits. So another issue we face is independent living, and that there are a lot of factors affecting that. What are the seizure types that patient have? What is the exact epilepsy syndrome? Community supports, their access to care, mental health, and treatment side effects. But we are able to work around them most often. There are different types of housings available. We can have health in home and home health agencies and long-term care pharmacies. For our epilepsy center, what we have done is, this is something physicians are not very familiar with, how to arrange this. This past year, I completed a graduation in something called Health Systems Academy. So it's kind of beyond medications and beyond surgeries and stuff like that, learning about these agencies, learning about these, how to help your patients with things that are not just medicines. And I don't think I still developed expertise. I just know that there are resources. So the best option for us turns out to be, we have in our center what is called as epilepsy nurse coordinator, and the coordinator can kind of get the information from the patients about what their needs are, and then find out where various supported living facilities or residential care facilities. And again, this list, as you start researching, it goes on and on. Now, we discussed the living issues, etc. How do patients with epilepsy feel? I think this should be something we think commonly. About 10 years ago, I remember at the American, 10 or probably 20 years ago, I think both me and my husband, we were asked to write a supplement on epilepsy and behavioral issues at the American Epilepsy Society conference. And this was based on the sessions there. And I remember there was something that we wrote about was epileptic personality. But what I came across was mainly there is loss of predictability in person's life. They don't know when a seizure is going to happen. So this makes them insecure, and it also makes a lot of their families insecure. And this leads to anxiety and depression. In general, the prevalence of psychiatric disorders in epilepsy is pretty high, as you can see with these numbers: depression, anxiety, bipolar disorder, and psychosis. Prevalence of epilepsy, this is in pharmacoresistant epilepsy especially, is really high compared to general population, even lifetime incidence of that, lifetime prevalence. So there are certain neuroanatomic mechanisms of depression and epilepsy. So there are brain regions that are affected in both depression and epilepsy. Very commonly are hippocampus, amygdala, and prefrontal cortex. And research suggests that because these regions are affected in both conditions, there is kind of a bidirectional relationship. And also, people who take medicines for depression, they can affect and increase seizures. Also, there is a list of some of them have a proconvulsant activity. So some antidepressants have low chances of causing seizures, and some have high chances of causing seizures. And there is wonderful literature on this. I would like to thank Andre Canners and Cynthia Harden. And there are various presentations on Annals of Neurology presentation collection. But I think this literature on this is growing. Now, at my center, what I have done is I am kind of a neurology teacher for psychiatry residents and psychiatry group. So during one of the lectures, one of my residents developed interest in epilepsy. So that person worked with me for 1 year. Later, Yale University had a fellowship in psychosomatic disorders. He did that and he completed and came back to us joined our faculty. So what we have been able to do is have sort of what I've created is an epilepsy psychiatry initiative. And I think even though our certification is American Board of Neurology and Psychiatry, we are more well-versed with neurology. I personally feel that the psychiatric medications are best managed by psychiatry. So I have a clinic, we have a clinic where the psychiatrist comes to my clinic and patients like that. Patients don't like to go to psychiatric clinic, but if a psychiatrist comes, I think we are able to manage these patients. But either case, we may not be able to have that kind of an arrangement every time. But I think this is a very special situation that doing antidepressant and antipsychotic medications in patients with epilepsy, specifically because many of these medications can increase the chances of your seizures. So I think resources for patients who need both would be important. And maybe that's one more thing I can add to my list of advocacy. Thank you for listening. I hope I kept the time and this wasn't too long. And my request to you is just anything that comes to mind, please contact the Epilepsy Foundations, and together we can work on this and advocate for anything and everything for epilepsy patients. Our goal is everyone should have perfectly normal life. Thank you. Any questions?
Thank you, Dr. Acharya.
I think I can stop sharing. Yeah.
Okay, that sounds good. If you and your husband could stay on, and then we are going to ask if people have questions after Dr. Jacobson speaks on any of the topics. So if you guys could stick around for that, that would be great. If you can't, we understand that as well. So, okay. Next up, I would like to introduce our next speaker. We were going to have a break, but we're going to go right into all our information has been so good, and we're just going to keep on sailing with the topic of comorbidity and epilepsy. And for that talk, we have Dr. Mercedes Jacobson. Dr. Jacobson serves as the Epilepsy Program Director and the Clerkship Director at Temple University Hospital. She received her medical degree from Columbia University and completed her neurology residency and was administrative chief resident in neurology at the Hospital of the University of Pennsylvania. Her research interests include women in epilepsy and epilepsy in the elderly. Dr. Jacobson is a valued member of the EFEPA Professional Advisory Board. So without further ado, I'd like to turn it over to Dr. Jacobson.
Can you guys hear me?
Yes, we can.
Okay. And let me just go to slideshow. I have a number of disclosures. First, I have not given this talk before, so you guys are my experimental audience. I have participated in investigational clinical trials, but none of that is relevant to this. And my third disclosure is that there are two dogs running around here, so the barking that occurs is really both of those. And you may, hopefully we won't see them. There are no treats in this room where I've stashed myself. My final disclosure is, so this is the first time I give this talk, and I wanted to have a little audience participation. I know people can be really shy, but I know that Courtney and Nicole are here, so I can always call on them if I can breathe. All right, so the goals and objectives of this little talk are to understand the concept of comorbidity. because my talk is epilepsy and comorbidity. In order to do that and to understand how it all comes into play, we'll talk a little bit about clinical reasoning, and how we implement it in patient care. Sorry. And as all of our other speakers have talked about, we've talked about, about how thinking about epilepsy is thinking beyond just the seizures. Sorry. So we need to define comorbidity. Because that is a not necessarily a common concept that you would be thinking about. And comorbidity is the presence of one or more additional conditions, often co-occurring with a primary condition. Comorbidity describes the effect of all other conditions an individual patient might have other than the primary condition of interest, and can be physiological or psychological. So like somebody got epilepsy, it's the other stuff that can go along with it. When we think about how the comorbidities impact our decisions, we think about clinical reasoning. And hopefully, when you go to the doctor explains things to you and you can understand at least some of the clinical reasoning. And sometimes you go to the doctor and the doctor knows you very well, or they've been doing it a long time, and you tell them 2 sentences and they say it's ABC. And you say, how did you know that? And some of that is just experience, but clinical reasoning is defined as the integration, organization, and interpretation of information gathered as part of medical problem solving. And so when we talk to people, an experienced physician engages in numerous tasks: listening to the story, reviewing the records, looking at the physical exam, choosing some studies, providing advice, and coming out with a final plan. So through clinical reasoning, we create a story from the patient's history, physical exam, test results, and serial observation to develop a plan. And so we look at the epilepsy, we look at the comorbidities, and we figure out what we want to do next. Pardon me. So this is the first time I've ever given this talk, and I thought we could divide comorbidities into 3 different flavors. And the first we're going to call category A. And our first 2 speakers have really talked about some of those. So that in category A, because a person has epilepsy, these other conditions are more likely, might be part of the brain illness or part of the overall syndrome. So for example, because a person has epilepsy, they're a little bit more likely to have some problems with memory or learning or depression. Category B will be our common comorbidities. And we talked about that, for example, with sleep disorders, common comorbidities. Anybody could have this problem, but if a person has epilepsy and the second problem, the second condition can impact living with epilepsy considerably. Just like in the very first lecture, we talked about how if the person has obstructive sleep apnea, that could affect their epilepsy, right? And then in category C, we think about complex or severe comorbidities. This person is quite fragile for many reasons, and the medical fragility may impact the way we manage our epilepsy. And I thought about putting these in these 3 categories, but I also thought about my audience, that my audience is really the epilepsy ambassadors, that everybody who came today is thinking about their own journey with seizures, but also they're their community expert. And so somebody's likely to ask you, so you have epilepsy, or somebody in your family has epilepsy, and I got this and my doctor said that. And so, you sort of become like the bartender at Cheers giving advice. And sometimes you're like, well, how did they come up with that? So by thinking about the comorbidities, you might see some of the reasoning and sometimes how we get from A to B. Does that make sense? All right, so an example comorbidity, our group A. Because a person has epilepsy, these conditions are more likely, might be part of the brain illness or part of the overall syndrome. memory loss, poor memory, depression, already covered by my earlier speakers, anxiety, learning disabilities. So because they have epilepsy, these other things go along with it. And because a person has epilepsy, in some cases, there are very specific things that a clinician should think about. So for example, if a person develops severe epilepsy early in life, they're more likely to have autism, autism spectrum disorder, and ADHD. If a person has Down syndrome, they are more likely to have heart disease. And as they reach their 40s or 50s, they are more likely to have sleep apnea and early onset dementia. So sleep apnea is the theme today. If a person has tuberous sclerosis, that might be a condition not familiar to many of you, but it's just an example. They are more likely to have benign tumors of the brain, kidneys, heart, lungs, liver, and skin. And any clinician should know that. But in addition, if a person has tuberous sclerosis and epilepsy, they're more likely to have behavioral and anxiety disorders, autism spectrum disorders, and attention deficit with hyperactivity. So those are common. If you have one, a good clinician should be thinking about the other stuff. Examples from what we'll call group B comorbidities, common comorbidities. Anybody can have this. You don't have to have epilepsy to have it, but the second condition can impact living with epilepsy: sleep disorders, diabetes, high cholesterol, high blood pressure, osteoporosis and osteopenia, alcohol use disorder, and mental health disorders, which can make it much harder for a person who has seizures to self-manage their epilepsy. So anybody can have these group B, right? Don't have to have epilepsy, but if you have it with epilepsy, it might change the medication choices or other aspects of the management. Now, in my category B, there's some important take-home points, and that take-home point is treating the treatable can help your brain. So when you have epilepsy, you're trying to make sure that your brain stays healthy. You know, if you're an adult with epilepsy, you're using it all the time and you don't want to lose any of it, and you want it to age as gracefully as you can. We talked about sleep disturbance disorders, which can affect seizure control and daytime memory. If a person with epilepsy has diabetes, we want it well controlled. We want to reduce their stroke risk. We want to hold on to what you got as you move into your 40s, 50s, 60s, 70s, and 80s. High cholesterol, again, untreated high cholesterol is not good for your brain, increases the stroke risk. We want to keep that under control. High blood pressure, deja vu, same thing. For many people with epilepsy, particularly people at midlife, they might have been exposed to some of the older seizure medications. In addition, if you're a woman with epilepsy of a certain age, maybe you didn't get to go to gym when you were a kid growing up. Maybe you didn't get to be on any sports teams. That could be true for men or women. And we think about osteoporosis and osteopenia. And so managing those and preventing those are important. Calcium and vitamin D is important. Exercise 3 times per week is helpful. And that exercise is also helpful for mindfulness and balance. Alcohol use disorder, we've talked about, but alcohol withdrawal seizures, not so good for anybody. And heavy alcohol use can impact memory, balance, and one's ability to take ownership of epilepsy care. Does that make sense to everybody?
It sure does.
Okay, smoking cessation. There's really no way around it. Nobody should smoke, but you shouldn't smoke if you have epilepsy. I did not know this until recently, but in the United States, 1 in 4 adults with epilepsy smoke cigarettes, which is higher incidence in the general population, which is only 1 in 6. There are higher rates of smoking in people with epilepsy, even if they're not under psychological distress. And smoking is not good for your brain. It's not good for anything. So if you love somebody who has seizures and smokes, we just got to work on getting them to quit. It's not good for any part of their body, brain, heart, nothing. There are other comorbidities that can impact epilepsy care. The liver, it cleans toxins from our body. If a person has liver disease, we might have to choose different seizure medicines or adjust the dosing. kidney disease. The kidneys make urine, control our body's pH, and excrete compounds. If the kidneys don't work, we may be going down a different route than we initially planned to. Living with HIV, seizure medicines should not interact with the life-sustaining retroviral medications. And transplant and also cancer patients often are taking specific medicines, and we can't give them a seizure medicine that will interfere with their life-sustaining medicines. All right, so we've gone through categories A and B. Category A, things that are really common with epilepsy. Category B, things that are common for everybody. And what I invented just for this talk is now group C, people who have epilepsy and 99 problems. So those are the people that might not be as familiar with this group, but you know, if you're at a soccer game and somebody says, "Hey, I know you know something about seizures. Somebody in my family has X," and you're going, "That is such a long story." But these are complex or severe comorbidities. The person is quite fragile, and for many reasons, the medical fragility might impact the way we manage their epilepsy. The clinical reasoning is essential, and so often, you know, as my co-speakers are very senior physicians, the clinical reasoning, the knowledge base, the ability to interact with the other doctors who are keeping that person alive is important. And it's not necessarily like living with epilepsy, but it's something that we do. So we might have somebody who has a brain tumor, has end-of-life hospice care, and has seizures. And so we might manage that in a very specific manner. An elderly person with heart failure where like one seizure and you know, that could be it. Cancer survivors, people who are being treated with specific medications like anticoagulation and blood thinners where they can't fall and have a seizure, but we can't give them a seizure medicine that's going to goof up the blood thinners. Major stroke survivors and people with the autoimmune diseases like lupus who are on a boatload of medicines and everything interacts with everything else. So those are sometimes our fragile patients. And so if somebody tells you this story, you're like, how did they do that? That's not what my doctor does, but it's because there's another, you know, there's another level of complexity. Does that make sense? Sort of. Okay. So now we have a little quiz. So I guess I can bother Nicole or Courtney or anybody. I have a group A type patient, and this is my sample patient. My slides have decided to move themselves to a new format, but I'll survive. Simon is my sample person I made up. He's an otherwise healthy 35-year-old male who has an epilepsy syndrome called juvenile myoclonic epilepsy. It runs in his family. He was treated when he was young with Dilantin or phenytoin. After 2 tours in the military, he was discharged. He was never injured, no head trauma, but he saw a lot of stuff and has post-traumatic epilepsy, PTSD, post-traumatic stress disorder, anxiety, and depression. So for my audience, I guess somebody will, I don't know if Carrie wants to read what the chat says, but what factors would go into Simon's choice for a seizure medicine? Anybody?
If everybody wants to, or anybody wants to use their chat box, just look at the bottom of your screen, click on that, and then you can interact with Dr. Jacobson.
For some reason, I don't see the chat. But
I see the chat and they're being shy, Dr. Jacobson.
All right. Nicole,
okay, here we go.
There?
So someone said side effects. They said, yes. What factors would go into Simon's choice of seizure medications? Side effects.
Right, and somebody said, excellent. So side effects, and somebody said, I would recommend staying away from anything that might not be good for mood. And so everybody's different, but some medicines might be more challenging for mood or emotional stuff. And somebody said Keppra or levetiracetam would make them kind of anxious because they don't think that's the greatest. And somebody else, Ginu Daniels, said, yes, pick a medicine that treats both epilepsy and depression. You guys, I can retire now. Daniel also said what medicines work for his family members. So absolutely, you guys don't even need me. I'm going home now. So there are a number of different medicines There are a number of different medicines that can be better for if somebody's suffered with depression. So lamotrigine, which is Lamictal, valproic acid, which is Depakote, and carbamazepine and its cousins. Carbamazepine is probably not your first drug of choice. And so we would stay away from a medicine that can increase irritability. I'm retiring. You guys did an amazing job. So, and I think one of the things that you brought out is some people do amazingly well with levetiracetam or Keppra, but for some people it will take them to a dark place. So it's one of those things. For some people, it is the best fit in the world, and for others, it is a lousy fit. So it's really thinking about the tailored depression. I'm blown away. All right. Are you guys ready for another case?
Yes.
Okay. Let's see if I can get to the next slide. Okay.
Somebody just said, please don't retire.
You're too sweet. All right. So this is our next made up case, and kind of is category A, kind of category B. Jason is a 50-year-old man who had a stroke 5 years ago. 3 years ago, he started having seizures, but he stopped his seizure medicine in 2020 because it was too expensive. During COVID, he gained 35 pounds. His wife sleeps on the couch because his snoring is so noisy. And he had 2 seizures last month. And so guys in the chat, any tests that you would recommend? So Kelly's like, sleep apnea, wonderful. Yes, so Kelly's like sleep apnea, and she's thinking that maybe she'll get a sleep study. And Carolyn is getting an EEG and MRI. And Leslie says, let's just admit him to the EMU and we can address everything at once. So I agree with all of those choices. So, but managing him for his sleep apnea, sleep study in the EMU. Yes, thank you. So we want to find out if he has obstructive sleep apnea and treat him. Anything that you think about in terms of choosing a medicine to treat his epilepsy? Check with companies and their patient assistance programs. You guys, I am definitely retiring. Absolutely. So you would want to know if there are any medicines that could be affordable for him. You might actually look at what's on the list of his formulary. And a person should always say, hey, doc, I can't afford this. Like I've had people who didn't even call when they had a problem and paid the money. Philadelphians are very cheap and we don't pay much for anything. And we always look to get it for less, but find out what's on the formulary for his insurance company. What's the paperwork? Could he get it for free? Ellen brought up GoodRx. Yes, Ellen, I am definitely retiring. GoodRx can bring down the price for many different people. And somebody said, maybe go to his local hospital medical assistance program. Absolutely. So look to see what's affordable for him and what are his avenues. Those are all good things. There's one thing we haven't thought about yet. Since he gained weight, CVS can give assistance with the pharmacy. That's right. And sometimes Target and Walmart too. And Elizabeth said, stay away from medicines that might cause weight gain. Absolutely. So that might be a factor as well in what you choose. So we want something that's affordable and isn't going to cause weight gain. And we're going to tailor whatever we pick to what's his insurance plan, what's available. We have people from all over the state of Pennsylvania, different counties, different programs, but look for something. Absolutely. All right, we're going to the next question. This is a group C. So this is somebody who's kind of medically fragile. Stay away from meds that might cause weight gain, yes. Who's kind of medically fragile. This is Jerry. He is a 70-year-old who a couple years ago when he developed diabetes, he had recurrent seizures every time his diabetes was out of control. Every time. It was terrible. He had what we call status epilepticus, and he was hospitalized in the ICU. So really as sick as you could. And then he had a long recovery to get back home. All of the seizures occurred in the first year that diabetes was diagnosed, and he's had no seizures in the past 5 years. He has had 6 follow-up EEGs without any sharp waves or spikes, no evidence of a seizure disorder, and less risk of having epilepsy. He's on low-dose Keppra or levetiracetam, and he's done well. So what do you think? Should we keep him on Keppra or take him off? Wendy is having trouble seeing the chat. So we have people saying, keep him on, take him off. And that's really interesting. And some people are saying, let's taper it. Other people are, why gamble? Follow him very closely. And so I think this is really like kind of the art of medicine. So, you know, if Jerry was your brother or your spouse, you might say, every time you went to the ICU, personally, I thought I was going to die myself. So please stay on, you're doing well. And some people would be like, I've been seizure free 5 years. I'm doing fine. I want to see if I can take one less medicine. So there's not, the final solution might be developed exactly what Jerry and Mrs. Jerry would like to do. His side effect profile, he's doing great. He doesn't have any side effects, right? And in real life, Jerry might say, I want to come off. And Mrs. Jerry would be like, you weren't there, you were unconscious. Dr. Jacobson, keep giving him the medicine because I'm not really ready for this transition. So it's clinical reasoning, it's an important conversation, it's allowing Mr. and Mrs. Jerry to know that you will support them through change, but whatever we decide to do is what is the right choice for them. Does that make sense? Okay. Let's see, I think I have another case. Now that I've stopped coughing. All right. Now I'm going to have to take you through a little more medical stuff for this one, but this is like something that really happens. Imagine it's January of 2021 and we're in Pennsylvania. Things were not so good then, right? Like we had COVID cases through the wazoo. It snowed like every day this winter. And you have a telehealth visit. And we learned about what's telehealth if we didn't already see it before. You know, you go on your cell phone, your computer, whatever, and you connect with your doctor. And there you are, having a little cup of coffee hidden on the side so nobody notices. And you have your next patient is Eliza, Miss Eliza. She lives in a rural place in central Pennsylvania, so she can just telehealth into Philadelphia because she couldn't come. Some time ago, she had a stroke in the occipital part of her brain, that's the back of her brain, that controls vision. And for the last 2 days, she's had these funny spells with her head turning to the left. Her left arm comes up in the air and her left arm shakes a little bit. And then after it resolves, she's back to herself. The spells last about 45 seconds. So my question for the group is, do you think that she might have developed epilepsy? Maybe she had a right occipital stroke and that controls the left side of the body. So Dana says, yeah, I think she probably has developed epilepsy. And so, yeah, everybody's saying yes, maybe. Now, in regular times, what would we do to figure this out? What would we do to know for sure if she had epilepsy? EEG, yes, an MRI, EEG, right? We have 1,000 people are like, Dr. Jacobson, get the EEG, look for sharpers and spikes. And Dana says, go straight to the emergency room, let's evaluate her. And in point of fact, we would normally look at an EEG and an MRI. And this past winter, we might not even be able to get the patient in. So we might have actually started treatment based on the clinical judgment. So again, like if somebody says, I had this, this, and this, and they just put me on meds, you know, there was a point where, you know, you could probably think this through and you might have had an 87-year-old family member who would not go to the emergency room this past winter because they were so afraid of everything. And so sometimes, you know, looks like a duck, quacks like a duck, and it should be considered to be a duck. But absolutely, you guys really can, you know, everything to do. All right. I think that I maybe, should be my last case. And this is another example of comorbidity and how we think things through. So this is another imaginary case. Melissa is now 22 years old, but at age 6, she had heart surgery. At age 7, she had a small stroke, but she recovered fully, grew up, went to high school, went to college, works in graphic design. Every once in a while, she has a flare-up of the inflammatory condition that caused her heart problems. She takes 3 medicines for her heart and 2 medicines for the autoimmune condition, for the inflammatory problem. So she's only 22 years old and she takes 5 medicines. And now she's got these seizures that are characterized by butterflies in her stomach and a brief confusion. So what factors would you guys consider if we were going to pick a medicine for her? Would you be worried about drug interactions? Interactions with her heart and autoimmune medicines? Absolutely. Anxiety, drug interactions. And so absolutely interactions with other medicines. And then would it be easier to add a medicine that's once a day or 3 times a day? Yeah, so there are probably people who on this chat who take 5 medicines. And so it's easier to, I agree completely with Leslie and Kiki, absolutely, that it is easier to take a medicine that is once a day than 3 times a day. And absolutely, you might start low dose rather than high dose because everything interacts, right? And interactions with autoimmune medication. So it could be really complicated. And, you might meet Melissa and you're like, well, how did they pick that one? And it could be based on all these other factors. All right. So in summary, comorbid factors can play a big role in the way we approach epilepsy care. And failure to, I'm just reiterating what my colleagues said, but what was absolutely came through in the chat. Failure to recognize and treat anxiety and depression has a negative impact in quality of life. And many people were talking about the fact that they took a seizure medicine and it brought them to a very dark place emotionally. Treating our comorbid conditions and keeping our brains and body healthy is essential for a good quality of life. And everybody has to take care of all of the parts of your body, exercise and everything else. And then finally, any brain can get epilepsy, but tailoring an approach to seizure care that incorporates the person, the care community, and the family goals is essential. And thank you.
Thank you, Dr. Jacobson. What I'd like to do now is we do have several questions that have popped up in the chat for various doctors here, so you can kind of just take it as you wish. Let me go back here and see. So we did have a question from Facebook. Someone said, is it common for rain and pressure change to cause seizures? So does someone want to take that?
No.
Jayant, Vinita, Dr. Jacobson, do you want to talk about that at all?
Not in my experience.
I'm sorry, I kind of missed the question. Was it about
the question was, does barometric change or change in the weather worsen seizures? Not usually in my experience.
Yeah, you're right. Yeah, I don't think there have been enough studies on that. Although I do have to, this is, well, it's not quite anecdotal evidence, but one of my colleagues had actually presented a poster at one of the American Epilepsy Society meetings many years ago, where he had someone actually look at changes in the electromagnetic activity of the Earth and found that there were certain patterns that were more commonly associated with seizures in some patients. I don't think he really got specifically into barometric pressure or weather changes, but there's really not much out there. And it's possible there's something, it just has not been studied adequately at this point.
Thank you for that. Dr. Jacobson, you referenced balance in your one slide, and someone wanted you to clarify that.
So,
Alcohol use disorder is the part of it.
oh, so I think that balance is in two places. So
Okay.
if a person is struggling with alcohol use disorder, it makes it harder for them to self-manage their epilepsy, to take their medicines on time. Dr. Acharya talked about the fact that alcohol can lower the seizure threshold if the doses are, if the alcohol is significant. And then chronic alcohol use can result in changes in parts of the balance center, the cerebellum, and that can make you increased risk of falling. And some people with epilepsy, particularly older adults who had a lot of the older seizure medicines for many years, may find that their balance isn't as good. The other area that we talked about balance was talking about osteoporosis and falls prevention. And so for basically all of us, as we get a little older, you want to have good core strength, good balance, and some degree of exercise is really important for osteoporosis prevention. So for many people with epilepsy, continuing to exercise and continuing to do something that looks at their balance and coordination is actually good for not only their brain, but for their general health.
Thank you for that. I had someone with a question. Do you have any comments about PRES or RCVS and seizures? Dr. Acharya, Vinita, Jayant?
So seizures in both PRES and RCVS, these conditions are they don't last forever. As long as the conditions get better, typically they don't need kind of lifelong treatment, or this is related to that condition. And unless there are specific risk factors, we continue medications only as long as patients have those conditions. So this is different from epilepsy per se. They are just associations with those conditions. And my co-speakers can share their experience, but I don't think most of us continue once that PRES is over, or RCVS is over. Is that, would you guys agree? Yeah.
Yes. So yeah, I think these are considered to be acute symptomatic seizures where you have this in that particular setting. Both of them are indeed associated with increased risk of seizures, but they probably would not need long-term treatment like a traditional patient with epilepsy.
Okay. I have another question. Can Celexa increase seizure activity even at low doses?
I think I can take that. Celexa does not increase seizure activity in low doses. And as a matter of fact, I would like to share something. Despite I started this fancy, epilepsy psychiatry clinic because I guess I did my fellowship maybe more than 25 years ago. And then we had very few medicines then on the market, maybe about 5 or 10. And today we have about 25. So similarly, in the field of psychiatry, there are more and more medications. And that's one of the reasons that's my psychiatrist treat the psychiatric conditions. Despite that, when I ask him what's one of the safest medications, something that if he's not there and I have to do this myself, I think Celexa is one of the good ones that is considered even by psychiatrists kind of low risk for causing seizures in epilepsy patients.
Thank you. This is a good question. It says, should I live with someone if I have uncontrolled seizures / drug resistance?
So who wants to take it? Yeah.
I think that if you have drug-resistant epilepsy, you should definitely, if you cannot live alone, that's good. You should live with somebody.
Yeah, I totally agree. Yeah, I think it is very helpful to have someone around, especially if you have drug-resistant epilepsy, not only to provide acute care, but also to reduce the risk of SUDEP. And so it would be very helpful, whether or not you want to share a bed with someone, that's maybe a different question, depending on what kind of seizures you have. But in general, it's probably not a good idea to live alone if you have drug-resistant epilepsy.
Okay, and then Dr. Jayant Acharya, you answered a question that was earlier, and I was hoping that everybody could hear your answer to this. It was, have you heard of music as a trigger for seizures? And so you did answer that person in the chat, but I wasn't sure if everybody had seen it. So could you just speak to what you said with that question, please?
Absolutely. So that's a very interesting question. So in general, music is helpful for people with epilepsy. And as I mentioned in my talk, there are some studies that suggest that creative forms of, creative therapy, so to speak, with art and music can actually help people with epilepsy. But there are certain rare forms of epilepsy called reflex epilepsy, where patients have seizures in relation to specific triggers. The most common one is flashing lights, which I just talked about at length in my talk. But there are a number of other unusual triggers that can cause seizures as well. And among them is music. So musicogenic epilepsy is a well-described type of reflex epilepsy, and often involves the temporal lobe, where we believe is the site for our musical appreciation, particularly the non-dominant temporal lobe. Now, with most forms of reflex epilepsy, the main form of treatment is to avoid the trigger, and sometimes you might need to take medicines as well. With musicogenic epilepsy, sometimes you can have an actual lesion in the brain, including the temporal lobe. And we have found in our experience, and it's also published in the literature, that in patients who don't respond to these types of treatments, you can actually perform surgery, removal of part of the temporal lobe, and make them seizure-free. And indeed, one of our patients had musicogenic epilepsy. She was actually a drummer in a band, I believe, and we were able to induce her seizures in our epilepsy monitoring unit by exposing her specifically to that music. And she also had some changes in her temporal lobe. And so we went ahead and operated on her, and she became seizure-free. So this is a very rare but unique type of epilepsy that can actually be treated surgically.
Thank you for that. Dr. Jacobson, do you have any tips to reduce irritability from Keppra? It's working and this person's fine, but they do notice that they're short on patience and more easily irritated.
So some people who take Keppra take a vitamin called B6. And sometimes there is success transitioning from Keppra, which is a levetiracetam, to brivaracetam, which is Brivact. So there are definitely people who will be able to transition from Keppra to Brivact, and that's all they need to do. Some people will take B6. In some cases, if the only medicine somebody's ever taken is Keppra, they may have a little bit of a challenge to go straight to Brivact. And Nicole is on our chat here. She may have some comments to type in the chat. And then, we saw a number of comments in the chat that, if you living with epilepsy means being yourself, and there are many medicines. So sometimes the transition isn't easy, But if you're really not yourself, then maybe it means that you change to a medicine that is a better fit for you.
Thank you for that. Somebody would like clarification. They're saying question for Dr. Acharya. I'm not sure if it's Jayant or Vinita. What's the difference of epilepsy and psychosomatic seizures? And then somebody else said, how common is PNES or non-epileptic seizures? So I do think this is kind of a gray area for people and kind of understanding what it is. So if
Yeah.
either Vinita or Jayant wanna, yeah.
Sure. So you agree with you, Carrie. It is a gray area and it's a symposium by itself. PNS, all is, it really definitely needs attention, but in common terms. So epileptic seizures kind of, they are arising from brain. So the simplest way to recognize these is if we repeatedly monitor these patients in the epilepsy monitoring unit. And when people have these episodes, there are certain semiological features which do not look like epileptic features. But more than that, when we have the video EEG correlation, the EEG remains normal. The seizures may look like patient may have tonic-clonic movements or everything just like an epileptic seizure, but the EEG kind of remains normal. One caveat to that is sometimes there are epileptic auras or seizures are coming from deep-seated structures or sometimes frontal lobe seizures where we may not pick up the changes, but by and large, we use the EEG testing, and there are certain features and comorbidities like, for example, history of abuse, history of depression, anxiety. There are many, so psychosomatic seizures or PNES is a category by itself. And the treatment is, the most common thing we see is the anti-seizure medicines do not work because this is not epilepsy. So we are not really treating the cause, and we need more of cognitive behavioral therapy or things like that. My co-speakers, anybody would like to add anything to that or has a different opinion, please go ahead.
I think you summarized it well.
I agree.
Thank you. I want to thank you. Thank you to the speakers. We went over time, and I'm very sorry about that. We try to be very mindful of that, but sometimes things happen. So we very much appreciate you staying on. Everybody had so many questions for you, and your presentations were fantastic. So thank you. We got some really great information tonight. Thank you to our sponsors who helped to make the evening possible. And thank you to all of our audience members who came on and spent their Tuesday evening with us. We very much appreciate it. So if you need anything at all or you have any follow-up questions, please reach out to the foundation, and we will absolutely circle back and help you with anything you might need. Okay? Okay, everyone. Thank you very much. And on that note, we're going to end the evening.
Thank you.
Good night.
Thank you. Good night.
Thanks for inviting us. And so nice to see you on Zoom.
Absolutely. You're not that far away, so you should come over to Hershey and give grand rounds or something. We can probably meet again.
And vice versa. All right, I'll let you go. Thank you.
Thank you.
Bye.